all protein is not albumin, and composition of normal urine protein excretion consists of albumin, which is 20 to 30 milligram, low molecular weight proteins, that is 10 to 20 milligrams, secreted protein, as in Tams Horsfall protein, which is generally a tubular protein, it is 40 to 60 milligrams. So how does this proteinuria occur? First, the glomerular filtration barrier consists of the fenestrate endothelium, the glomerular basement membrane, the podocytes along with the slit diaphragm between the interdigitating food processes. In a more graphic presentation, I have here, this is, as we all know, our kidneys. If I take a cross section of it, this is the whole Bowman's capsule along with the glomerulus. Take a small section and magnify it into an electron microscope, is something, a picture, something very similar to this. And another cross section, extremely nanomicron thing, we will get it here. These are the podocytes. Actually, the food processes of the podocytes, which are epithelial cells over the glomerulus. And this is the basement membrane where my cursor is. And these are the slit diaphragm. Any breach in the slit diaphragm is what is the mechanism of proteinuria. So to classify proteinuria, there are various ways we can classify this proteinuria. One is based on the amount of protein. That depends, that again, it's divided into the nephrotic and non-nephrotic. The type of proteinuria, we would have exclusively albumin, that is albuminuria, and then divided into a low molecular weight proteinuria. I would expand this by saying low molecular weight protein would be your light chains, the high molecular weight proteins, and the low molecular weight proteins, the light chain, the lysozymes, the myoglobulins, etc. The underlying pathological damage can be a non-glomerular and a glomerular. Then classifying protein again on the basis of how they are produced, if it is a tubular proteinuria, or it is an overflow proteinuria, or it is a glomerular proteinuria. I will start from below. To classify or to describe tubular proteinuria, it occurs in diseases affecting tubular interstitium of the kidney, and typical consists of tubular proteins like alpha-1 or beta-2 microglobulin, and like as I said, non-albumin, so the molecular weight would be less than 25 kilodaltons. Some amount of albuminuria can be seen in tubular interstitial disease, which is secondary to impaired reabsorption. Typically, the patient, when does a 24-hour urine protein, would be less than 2 grams per day. And dipstick, that is our urine report, generally will come as negative. In overflow proteinuria, here associated with increased production of abnormal low molecular weight proteins beyond the capacity that can be handled by kidneys. If you remember in multiple chain myeloma, what happens is normally our body would produce light chains. It is only when the proteinuria is in excess of the normal production, it tends to overflow into the urine, and that is why we get light chains in our urine. So that is the case in multiple myeloma, and it is an overflow proteinuria. Similarly, when there is a trauma and there is rhabdomyolysis, myoglobulin is what shows us overflow proteinuria. Same in Did you lose me in between?
No. Perfect.
Okay, so myoglobulin in rhabdomyolysis, then lysozyme in acute myeloid leukemia, and when we have intravascular hemolysis like in DIC, we will get free HB, which we consider in a nephrology point of view as a protein, and that also is a form of overflow proteinuria. The next is glomerular proteinuria. It can be of 3 types. There is one is transient, or what is the functional. Then is the orthostatic. Then third is the persistent or the fixed. This persistent or fixed is again divided into a nephrotic range proteinuria and a non-nephrotic range proteinuria. Coming to transient or functional, it can occur in any conditions as in fever, exercise, heart failure, hyperadrenergic states, or hyperanemic states. Usually when the patient does a 24-hour urine protein, it will be less than 1 gram in 24 hours. This is due to an increase in single nephron flow or pressure. When we do all the blood tests, normal renal functions, normal blood pressure, and a urine test will be bland. In an orthostatic proteinuria, this is diagnosed when a patient has no proteinuria in early morning sample, but over the day he tends to show protein in urine. Usually it is less than 1 gram per day. The patient will have a normal renal function and the urine examination will not have any hematuria. That means they will not show any RBCs. The possible mechanism of orthostatic proteinuria would be if a person stands upright, there is a reduced renal plasma flow and GFR. There is a low streaming potential across the filtration barrier. Hence, albumin cannot be filtered efficiently and then appears in urine. The prognosis is good. When we counsel patients, we have to say them not to be scared and the prognosis is good. And generally, biopsy is not indicated in this orthostatic proteinuria. Then comes isolated proteinuria. It is a fixed non-nephrotic. Proteinuria generally will be less than 3.5 grams in 24 hours. Again, the patient will have no history of diabetes or hypertension. On doing the renal function test, it will be all normal. The urine sediments or the complete urine examination also will be normal. Any workup of autoimmune, whether it is complements or ANCA, ANA, everything will be negative. But a prolonged follow-up is needed for such kind of patients. Biopsy usually is not done, but some nephrologists, if the proteinuria goes beyond 1 gram and patients tends to have edema, they will go ahead and do a renal biopsy. However, when it comes out to be a normal protein and normal glomerular structure on a biopsy, treatment is not indicated. Then comes what we are all aware of, and of course know, is a nephrotic range proteinuria. The proteinuria is more than 3.5 grams per day. There is an active urine sediment, dysmorphic RBCs or RBC cast. I would like to add here is that when we define active urine sediment, it is all for students, is that when you see in your microscope a urine sample and take it in that single cross section that you are seeing, there has to be at least 1 RBC cast or 5 dysmorphic RBC or 50 RBC. This is how we define an active urine sediment. Then other features of nephrotic range proteinuria, hypoalbuminemia, lipiduria or hyperlipidemia, edema, hypertension, abnormal GFR, which again is calculated if there is a high creatinine, and biopsy is a definite indication for diagnosis as well as management. Post-renal proteinuria. Here there is protein in urine, in urinary tract infections, and which again causes an increased protein excretion. However, the protein that are produced in the urine or which are secreted in the urine in a non-albumic protein like IgA or IgG. Then another classification of proteinuria is on the type of protein, where it can be microalbuminemia or macro. So persistent albumin excretion between 30 to 300 milligram per day is called microalbuminuria. But recently, the recent KDIGO guidelines over the last 2 years have made this term microalbuminuria a kind of little obsolete, and the new term that is being used is moderately increased albuminuria. And it is a very important indicator of incipient, or what I would say as an early stages of diabetic nephropathy. However, if the patient is not diabetic, it is again a very silent and a dangerous indicator of cardiovascular disease. Albuminuria more than 300 milligram per day is overt proteinuria or macroalbuminuria. Again, KDIGO defines it as severely increased albuminuria. How do we detect and measure urinary proteins? So there are two methods, qualitative test and quantitative. Qualitative test again is standard urine dipsticks and sulfosalicylic acid. For standard urine dipstick is what most of you would be treating nephrotic children, and this is what we advise the parents to do every day, every morning, and that is primarily detects only albumin. So this is generally what we use for a dipsticks test. So this detects only albumin, relatively insensitive to non-albumin protein because reagent on test strips, bromophenol blue is highly specific only for albumin. High specificity but low sensitivity for low levels of albumin, and lower limit of detection in urine albumin concentration of 10 to 20 milligram per deciliter. However, it is still unable to detect microalbuminuria. So here, this is how we do it, and this is how we teach our parents of nephrotic children to do it every morning. The color changes on the dipstick, and then it is used against the file which is over there, and the parents are taught how to see the color changes according to it and then quantify it to us. And everybody is asked to prepare to keep a book and to keep it charted. Then comes, what are the false positive and negative? The false positive again is high alkaline pH. If immediately after an iodinated contrast we have done the test, which is not even less than 24 hours, or there is a gross hematuria, or we have cleaned the bottle as well as the urine bottle container with antiseptics like chlorhexidine, or the urine itself is highly concentrated. False negative dipsticks will be when there is a non-albumin protein. This is important for us because, like I mentioned, myeloma chains, they will not be detected, but they are definitely present. So that means that even if it is a non-albumin, the protein still is being leaked, though it is a non-albumin protein. And false negative is seen in very dilute urine and acidic pH. The next comes SSA test, or the sulfur salicylic acid test. I'm sure most of us remember doing this in the biochemistry labs. So way back when we were doing our MBBS, so detects all protein and not just albumin. So it has the lowest sensitivity at the concentration of 5 to 10 milligram per deciliter. So SSA positive and dipstick negative, very likely immunoglobulin light chains. So here it's a very important test for us to know whether it is a nephrotic proteinuria, which has specifically albumin, or it has other light chains like your myeloma chains or your amyloid proteins. So 1 part of urine supernatant plus 3 part of SSA, we get turbidity as per the amount of protein present in the urine. However, finally, it is the gold standard for quantification of urine is the 24-hour urine protein. So why is this quantification important? First, it gives us the degree of proteinuria is prognostically important. If it is 1+, we are still safe. If it is 2+, we are okay. But if it goes beyond 3+, then definitely it is a danger signal. Degree of proteinuria is used to monitor therapy. So we do a 24-hour urine protein. We assess how much of protein the patient is leaking, give him a diagnosis, start the treatment, ask him to come back after a month and do a 24-hour urine protein again. Once we get the report and see how the patient is doing, whether the 24-hour urine protein is decreasing or not. So this definitely is used to monitor therapy. The benign forms have less than 1 to 2 grams per day, and the severe forms have more than 3.5 grams per day. So the best method for albumin detection for 24 hours is HPCL, which is the high performance liquid chromatography. And the positive point for 24-hour urine sample is that it overcomes the barrier of circadian rhythm and the orthostatic proteinuria. The disadvantages are it is cumbersome, impractical in certain situations like children, elderly, outpatients, over collection and under collection. For us, in Maldives, it is very difficult, especially in Malé, when patients have to catch their flight or they have to catch their boat back to their island. 24-hour urine protein becomes extremely difficult to explain. Adequacy of sample, total urine creatinine. So normal urine creatinine excretion per day in men is 20 to 25 and in 15 to 20 in women. This is in milligram per kg. So the average creatinine excretion on a population level is assumed to be 1000 milligram per day. So how is the UPCR or the urine protein creatinine ratio helpful? The ratio between the urine protein as in 24-hour sample and the urine creatinine excretion is generally expressed as in milligram per gram mg. It is just like an INR ratio. This urine protein creatinine ratio is also a single number because the milligram and the milligram both cancel each other, and what we get is a definitive number. Easy to obtain and not influenced by water intake. However, UPCR correlates very well with 24-hour urine protein on a population level, but definitely not on an individual level. So the limitations are the urine protein creatinine ratio or the urine albumin creatinine ratio are heavily influenced by the urine creatinine excretion. When I say urine creatinine excretion, definitely the muscle mass comes into play. So patient with large muscle mass underestimates, and patient with small muscle mass always tend to overestimate. Urine protein excretion can vary throughout the day, like I mentioned, in exercise, or it is an orthostatic proteinuria as in posture, and definitely there is a diurnal variation. So an estimated albumin excretion rate is in AER or the EPER. Some of nephrologists do not follow this. This again is a standardized protocol. Some go by 24-hour urine protein or some go by UPCR. Spot urine albumin is to creatinine ratio multiplied by the expected 24-hour creatinine generation. Expected or the estimated albumin excretion rate or the EPER is more accurate and less biased than ACR in predicting a 24-hour urine albumin, especially in patients with a large or small muscle mass. But are such minor variations in protein measurement clinically important? Well, the answer is no. What is important is most reproducibility of the test, and second, changes in proteinuria with therapy. So the ideal approach may be a 24-hour urine collection during the initial evaluation, both protein and creatinine, then EPER on this 24-hour sample compared with a random sample. On subsequent visits, EPER used, and if EPER shows significant change during follow-up, repeat the 24-hour protein. So these are all the causes of glomerular proteinuria, and with active urine sediments, with bland sediments, with again secondary glomerular conditions like lupus, anti-GBM, vasculitis, PIGN, HSP, bacterial endocarditis, and with bland sediments, non-proliferative like diabetes, hypertension, amyloid, nephrosclerosis. So these are basically all the conditions that occurs secondary to proteinuria, and the biopsy is what gives us the whole idea about what exactly the patient has, and this is how we treat the patient as to which particular condition the patient has. Finally, my approach to a patient with proteinuria. So once the patient comes to us with a urine report or a 24-hour urine protein report or a UPCR report, patient is having proteinuria. It is established. Then repeat test 2 to 3 times if the patient is still with you, and which includes early morning samples, and take a detailed history and clinical examination. So there are 4 scenarios that we would get. 1, patient must have had fever, must have had UTI, or must have heavily exercised and in particular had gone to a gym, and then we continue to do repeat test 2 or 3 times, and then it all comes out to be a negative. So this is all cleared now. Second scenario, no proteinuria in the morning sample, but present during the day. Third scenario is there is persistent isolated proteinuria. And the fourth scenario is persistent proteinuria with hematuria. Like I said, scenario A, repeat tests are negative, reassure the patient and let him go. The second scenario B, there is no proteinuria in the morning sample, but present during the day. Check his blood pressure every time he comes to the OPD, do an ultrasound, check the RFT, that is the creatinine, uric acid and urea. If all is normal, reassure and discharge the patient. Then comes third scenario, persistent isolated proteinuria. Assess the blood pressure, quantitate the proteinuria, 24-hour urine protein, get an ultrasound done, estimate the GFR. It can be an eGFR or even a simple creatinine report is enough. Serum complements, it's still C3, C4 is fine with us, but if we can go ahead as per the history, if the patient has an autoimmune condition, ANA, dsDNA, ANCA, all helps. If everything is normal, reassure, but keep the patient in follow-up every 6 months and do a GFR estimation yearly. If the protein disappears or becomes intermittent, reassure the patient and discharge. But if the protein continues to be close to 2 or close to a nephrotic range and GFR and BP is normal, continue an annual checkup. I would suggest continue checkup every 6 months. And If, however, all these conditions of blood pressure, 24-hour urine protein, ultrasound, even if any of the reports are not normal, then please go ahead and do a renal biopsy. As per the renal biopsy, target your management. But however, if the GFR falls and BP rises, proteinuria 2 grams, hematuria, in the scenario of B, then you can go ahead and do a renal biopsy. So the last is persistent proteinuria plus hematuria. Assess blood pressure. Again, quantitate the protein with 24-hour urine protein, ultrasound, GFR, complements. If it is abnormal, renal biopsy, and treat the patient as per whatever the biopsy result comes. If all are normal, annual checkup. Query on biopsy, it again, however, the KDIGO guidelines tell us to check up the patient every annually. But some nephrologists would still prefer, because if the complements are normal and the patient continues to have persistent proteinuria and hematuria, certain other conditions like Alport's and Pearson syndromes, where it is a genetically mutated disease and we would not get any of the reports to be abnormal, we still go ahead and do a biopsy, at least for the prognostication of the patient. So my take-home messages tonight are: proteinuria is not always pathological. There are reversible causes like UTI, fever, exercise, hyperadrenergic states. Quantification of proteinuria is extremely important. Although qualitative tests are the one done first, gold standard test for the quantification is always 24-hour urine protein. Urine dipsticks cannot detect microalbuminuria and non-albumin protein. This is to kept in mind so that we do not miss out a multiple myeloma or an amyloid. And close follow-up of patient is necessary, even if they are not being treated. Thank you very much.
Sorry, it seems my mic was mute. Thank you. Thank you, Dr. Bhumika. It was
very well presented presentation with a short notice. You have given a very brief and important points for us to remember. Well, if there's any questions from anyone, I think we'll give some few minutes for the questions, if at all it's there. I hope you can hear, all of you can hear me. If there's any question, you can even type in the chat bar, or you can just unmute yourself and ask. Or at the end of the presentations, we'll give some time for the questions. A short question I have is, we being physicians, we have sometimes difficulty in checking a diabetic patient having proteinuria. It's difficult initially, but then we used to say that we check retinopathy, whether there is a diabetic retinopathy or not. If it is there, then probably this kidney is due to the protein is due to the diabetes. So can you just shed some light to this fact?
Yeah, yes. Yeah, Dr. Ali, yes, that definitely when a patient is diabetic and presents to us with proteinuria, our thought process would be that it can be because of diabetes. But there are certain indications of doing a biopsy in diabetic patients. And
Yes.
first is that when you mention retinopathy, there is a particular guideline as to 60% of patients All over the research has told that 60% of patients generally who have diabetes and as well as diabetic retinopathy tend to have diabetic nephropathy as well. But there are still 40% who escape that. And for that 40%, we still have to go ahead and do biopsy. Precisely, there are again certain indications of doing biopsy or which tells us that the patient's proteinuria can be because of diabetes or the patient itself has a nephrological problem. That can be secondary to any other glomerular diseases that we see. Most common in Southeast Asia would be an IgA nephropathy, or it could be membranous, because membranous is one of the most common glomerular disease which is seen in a patients with diabetes. So there are certain indications, like if there is an overt nephrotic range proteinuria, as in more than 3.5 grams, if the patient's proteinuria in 24 hours is going 7 grams, 8 grams, then it is not diabetic. It is something more than diabetic.
Yes.
If the patient
Okay.
is, yeah, there are other guidelines, there are other points
Yeah.
as well. When the patient is having other symptoms like autoimmune conditions and has history strongly towards autoimmune, then also we go ahead and do a biopsy. Or if
Okay. Thank you.
yeah, okay.
Yeah. Okay. Thank you so much for the answers, and it's so informative. So moving on, I think we'll go for the next presenter, Dr. Palani. Since we have a lot of gastritis and gastric related issues in our community, and sometimes it doesn't even resolve without the treatment. But so let's talk about some advances in gastroenterology. Which the topic is endosonography and ERCP and overview. Dr. Palani, I think the screen is for you.
Yeah.
Please proceed.
Yeah, good evening, all. I thank the faculty of IGMH and the Maldives Association of this meeting for giving me this good opportunity. Am I audible and my clips are visible, sir? My topic is on endoscopic ultrasound and ERC. These are the recent advancements. Recent advancements in the field of gastroenterology. For we are aware that endoscopy like upper GI, colonoscopy, enteroscopy, sigmoidoscopy is there. Endosonography is coupling of endoscopy and ultrasound. The room looks like this. One is the monitor, the other one is the ultrasound monitor. The patient lies which we all would have seen in routine endoscopy, and the scope is almost the same. It looks like the same only. There are two scopes. One is a radial, other one is a linear scope. The frequency of resolution is 3.5 to 10 is more than ultrasound, routine transcutaneous ultrasound, and the point-to-point resolution is 2 millimeter. The depth of resolution is 5 centimeter. It also has Doppler potential. So when we screen the structures, we notice a solid organ or a vascular organ. So what we achieve? We achieve high resolution image of what we achieve of the lumen of the GI tract, the wall of the GI tract, and more importantly, structures which lie outside the GI tract. Meaning, when you are in the esophagus, we can screen the mediastinum. When in the stomach, we can screen the retroperitoneum, bile duct, pancreatic duct, pancreas. And when in the rectum, we can screen renal structures. We not only screen that, we get a very good tissue sample in a very safe, effective manner. It is done as an outpatient procedure, 80%. The risks are very less. Infection, bleeding, perforation, which are to the tune of less than 3%. So, to depict clearly what we do, the scope passes through the esophagus, screen the mediastinum, and we can take sample the wall, lumen, or from outside the wall. So, patient who has nodes, who has a cyst, who presents with anorexia of unknown origin, weight loss of undetectable origin. To take a sample node, so far we have been doing mediastinoscopy, but here, OP procedure, we can do this. To say an example, this is a 36-year-old lady who, this is an endoscopy, there's an ulcer. If you see here, you can see the ulcer now. I hope you can ulcer. Sorry. This is the ulcer. Hope you can appreciate that. This ulcer biopsy was done outside by endoscope. It benign, but the ulcer was looking more thick, inverted, and edematous edges. So what we did was, we did endoscopic, that is, in the same sitting, we switch to endoscopic ultrasound, and here you can appreciate, this is the, just imagine this is the endoscope, and this is the cardiac structure. Normally, the cardiac structure should to the esophagus, but here there is a very big node. So then we understand that it is a mediastinal node eroding the esophagus, causing the esophageal ulcer, and so we did biopsy. You can appreciate here that we are doing a biopsy of the node. I hope you can appreciate the needle there. This is the needle. You can see now. Can you see the needles? And these are the cardiac structures. It was returned as granular tuberculosis, treated with ATT. What was thought as turned out to be a treatable medical benign condition. 1 year later, she was reviewed, doing well. The endosonography will do in esophagus. Now we can see what we can do in stomach. As the scope goes, we can, from the stomach, we can screen the pancreas from head to tail explicitly, because there are areas where the existing CT or MRI may not give a answer. So these are the conditions where we can screen the pancreas. Screen the pancreas, we can screen the bile duct, we can screen the pancreatic duct, and we can screen the pancreas completely. How we do this? You pump along the stomach, above, middle, below. You can screen the pancreas completely. Hope you understood the anatomical issue. Two examples. First, I will take cystic lesions of pancreas, then solid lesions of. This was an alcoholic patient, pancreatitis. On follow-up, this MRI picture shows a cyst in the head of the pancreas. This is the bile duct. This is the pancreatic duct. This is the gallbladder. This cyst was initially thought to be a pseudocyst. So they thought we can leave it. The patient we took for endosonography, the scope is in the, and we punctured the cyst. You can observe in this video. We can see the bile duct. This is the bile duct. This is the cyst. Moment, you can observe that needle was passed into the cyst. The needle is coming here. That's a needle through the duodenum into the cyst. You can see the needle. From this fluid, we assessed carcinoembryogenic antigen of the fluid, amylase of the fluid, cytology of the fluid. Amylase was very low. That is its process, what was thought before from the MRI. Carcinoembryogenic antigen and cytology was positive. So this case is a case of adenocarcinoma. He underwent Whipple's. Otherwise, we would have overlooked thinking it to be a pseudocyst. Case number 2. This is a 53-year-old female who had a cyst in the head of the pancreas. See, this is the CT scan. It's showing a small cyst. But what happened was, this lady was very anxious and she wanted to know what is the reason for the cyst. But we did an endoscopic ultrasound. Scope is in the duodenum and we are screening it. As we are screening it, we had some difficulty. That is, you can see the cyst is here, what we are seeing in the CT, but there's a big vessel running on the surface. This is the scope. So between the scope and the cyst, there's a big vessel. But endoscopic ultrasound, what we can do is, we can rotate the scope, avascular window, and through that window, we punctured, we got the fluid, and to the happiness of the patient, was normal. CEA, which was high in the previous case, in this case was normal. Cytology was negative. We told her that it is a benign cyst, just to forget, worry about that at all. Because we know cyst in the head of the pancreas or cyst in the pancreas can be a benign condition to malignancy. It can be anything. So this is it. And this is another cyst, a young man who had a cyst in the head of the pancreas. This is the duodenum with the contrast, liver, stomach, bowel, duodenum. This is a cyst. We punctured this cyst, and to my surprise, my anesthetist asked me whether I am aspirating the propofol what he is injecting. The fluid was milky white. So then we understood that this is nothing to worry. Lymphocele of pancreas. So what was thought as maybe something else on imaging turned purely a benign issue. So these are all the cystic lesions. What solid lesions? This was a patient who had nodes in the pancreatic region. The treating faculty thought these are the nodes. Hope you can see the nodes here. These are the 2 nodes, rectangular nodes. The portal vein, you can appreciate. This was thought as an occult or in the pancreas with the peripancreatic node. So they wanted to do an Whipple's. But an endoscopic ultrasound, and you can appreciate here, the needle comes through the node into also. There's a node they're taking a sample through the duodenum. This was all to be a granulomatous lesion. So what was thought as a malignancy turned out to be pancreatic tuberculosis, treated with antibiotic, ATT, recovered. Incidentally, the patient was a father of my 1-year senior colleague. He was so happy to have understood this. This is another solid lesion in the pancreas. This patient is a case of hypoglycemia, biochemical hypoglycemia, and clinical hypoglycemia. Clinically, insulinoma was suspected. That is, insulin levels were high, proinsulin high, but CT or MRI couldn't pick up because they are all small, we know. So such a small lesions in the pancreas, endoscopic ultrasound is the best because the scope is in the stomach and we see the pancreas very clearly, explicitly, completely. This was what happened in this. Hope you can understand this. We started screening the pancreas. The scope is here. This is endoscope. We are bothered. See, am I rotating the scope, rotating body to body of the pancreas and tail of the. Now you can appreciate that the tail of the pancreas is seen. If you observe clearly, why I say tail is, this is kidney, this is spleen, this is pancreas, and this is the tail of the pancreas. In the high spleen, there is a coin-like lesion hanging from the pancreas. This sample, this, hope you could appreciate that nodule, kidney, spleen, and the pancreas tail. That is, I am screening the left side, left upper abdomen of the patient. For this, we did an endoscopic ultrasound. Sampling was done. This turned a neuroendocrine tumor. So what hope you could appreciate now. Doppler has been applied. Patient is not taking Doppler. And this is the needle here. In the real time, we are taking a sample. This turned out to be neuroendocrine tumor, insulinoma. Patient underwent surgery, recovered from her continuous hyperglycemic episodes. I have spoken about the diagnostic issues of endoscopic ultrasound. What therapy we can do? Patient with a pseudocyst in the pancreas, and this is the scope. What we did was we screened the cyst, and from the stomach with the endoscopy view, this is the endosono view. You understand? From the stomach, we punctured. We are puncturing here over the cyst, which is causing an impression on the stomach. The needle was here, the real time you are seeing here on the US. We punctured here in scopy, and we are seeing the needle here real time, over which guide wire was passed. Over the guide wire, this is the guide wire. You can see the fluid gushing out here from the cyst into the stomach. See the fluid in a moment now. The guide wire is seen in the endoscopic ultrasound. See, the fluid is gushing out. You could see it. And through this wire, we dilated the tract, and through the tract, 2 stents were placed. So these are 2 stents. The patient was called 3 months later. The cyst has regressed and he recovered. So that is one therapy from US. This is a patient who is a CA head of the pancreas, operated, but still she has intolerance despite morphine, tramadol, or whatever parasite we give. US can do is pass the scope, screen the aorta. We know that the first branch is a celiac. This is a celiac trunk. This is the aorta. And we know the celiac ganglion lies. The celiac ganglion lies on the surface of the celiac trunk. So to that area, we inject the agent, bupivacaine and alcohol. So that's what we have done here. You can see this is the, I'm saying from the stomach. You have to imagine that. This is the aorta. I'm enlarging the view. This is the celiac trunk. Oh, copper is applied and you know that. And now what I have to do is I have to bring the needle and inject here, deliver the anesthetic agent. We injected alcohol and bupivacaine. The very good pain relief. This is celiac plexus block. Otherwise, we do it in a retrograde CT guided manner. Here it is antegrade manner, safe, real time, and it is good and quick. So here you can appreciate the needle and it delivers the agent over here. Since it is Doppler is there, we can stop that not injecting the vessel. So now having spoken about what diagnosis, what therapeutic use can do, now hello? Hello? I want to talk.
Doctor, please continue.
Yeah, okay. So now I'm talking to EUS and ERCP can combine together. See, this is the patient who presented to us in severe abdominal. She knows that she had a gallstone for 6 months, but she was jumping in pain and jaundice. Her LFT was abnormal. So we know that probably the stone has slipped bile duct. She warranted an ERCP to remove the stone. So what we did was endoscopic ultrasound. The scope is in the duodenum. This is the endoscopy view, which we don't want. US view. This is the gallbladder with the stone. From the duodenum, we are screening the bile duct. See, can you appreciate the bile duct? This is the bile duct. There. So in the same sitting, we identified the stone is there, and in the same anesthesia, we switched over to ERCP. We the stone. This is the stone. Can you appreciate, sir? This is from the duodenum. By the balloon, we are pulling out the stone. So in the same sitting, the US and ERCP, and she was relieved of her. This is a multiple stone. Can you see that? Crushed and stone is into the duodenum. So this is what ERCP will help us. And this is similar such case where there was, this is the bile duct. This is the scope. There is a stricture here. we dilated the stricture and we deployed 2 stents. So previously we saw a case of stone. Now we see a case of a stricture. Another road traffic accident case where in the cholangiogram there was bile leak. You can see the leak here. Hope you could appreciate the leak here. So we did an ERCP, did a stent, recovered. So stone removal, stricture dilatation, leak sealing we can do. And this is another interesting case where he reported to us. He reported to us with a stone in the bile duct. You can appreciate the stone here. This is the bile duct. The stone here. I hope you could see. You could appreciate it. But the issue was, this underwent a imaging 4 weeks back, and asking us to do an ERCP with the imaging of 4 weeks back. So we did a US. This is the pancreatic duct. You could appreciate that both are coming in joint ampulla. We did an ERCP. The stone was cleared, and she recovered from her abdominal pain. So what ERCP, what in bile duct we have seen, now ERCP in pancreatic duct. This is an MRI picture. This is the bile duct. This is the gallbladder. These are the pancreatic duct with stones. For this, we did an ERCP and put a stent. You can appreciate here the pancreatic duct is very much dilated. Normally the pancreatic duct is very pencil thin. We did a stenting and the patient recovered from the pain. So now having seen EUS and ERCP, what we can do is in the esophagus, we can see in the duodenum, we can see the retroperitoneum, and from the stomach, we can see the retroperitoneum. And in ER, we can deal bile duct and pancreatic duct issues. The complications than 4 to 5%, like pancreatitis, bleeding, or perforation, but experienced and hand, the complications, and I have initially when I started, the complications were there, but over the period, now we are able to handle it in a very safe and effective manner. I'm concluding that what endoscopic ultrasound and what ERCP can in treating our patients and giving them a good relief, and what are the indications and what are the complications with. So I would like to conclude my topic. So this is what US, we see only one deer here, but actually there are 3-4 deers in the silhouette. That's what US does us. What CT or MRI helps us getting an answer, not helping us in getting an answer. US will be an answer. I thank you for and thank for giving me this good opportunity.
Thank you, Dr. Palani. It was a very interesting topic you have presented. I mean, most of us didn't even know that this kind of interventions are being done in gastroenterology. So it was very interesting. I think some of the physicians or some of us would be very interested to pursue our studies in gastroenterology by hearing this kind of interesting interventions. So if anyone has any questions, you can unmute and ask a question, or you can type in the chat bar. We'll give a few minutes.
I wish to, 1 minute. I wish to thank Dr. Isnim also for giving this. It's only through him that I prepared this talk.
Yeah. So if anyone has any topic, sorry, any questions, you can ask to Dr. Palani. It is very difficult to meet him most of the time, not because he is not available. He's always available because he's busy most of the time with our gastric issues and a lot of referrals. So if anyone is having any questions, you can ask through the chat bar, or you can unmute and ask. Okay, I think if no one has a question, you're going for the. Thank you, Dr. Palani, for your presentation.
Thank you. Thanks.
We're going for the.
Yeah. Thank you very much.
Yeah, welcome. We're going to the next topic, which is for in a case of triple negative breast cancer by Dr. Kamaraj Soti. He's a consultant oncologist. I think this will be very interesting to us to listen to this case. Dr. Kamal, if you are here, please start. The screen is for you.
Thank you, Dr. Mohamed. Good evening, everyone. Today, I will be discussing triple negative breast carcinoma. It was an early and locally advanced breast carcinoma, which who received treatment in Maldives. So we will be reflecting on the different issues of triple negative breast carcinoma. I chose this patient because of the worst outcome of this patient in a clinical scenario. When we talk about breast carcinoma, the triple negative breast carcinoma is the subtype which has got a poor outcome. There is an immense need of doing an immunohistochemistry to diagnose such patients. And yes, we need to explore for the different treatment options of giving chemotherapy before or after the surgery. The relevance of knowing about the pathological complete response and adding adjuvant chemotherapy in such patients to improve the treatment outcome should be discussed in forum like this. Yes, triple negative breast cancer fall into high risk groups, so they require radiation therapy, and we will also invest our time for the therapeutic implication while we do BRCA gene testing in patients with breast carcinoma, and the evolving newer treatment of PARP inhibitor and immunotherapy in triple negative breast carcinoma. Our patient was a 61-year-old Maldivian lady with hypertension and dyslipidemia. She was evaluated for right breast lump. A mammography was done, which revealed BIRATS 4A. Biopsy was done, which was suggestive of invasive ductal cell carcinoma, grade 3. She underwent breast conserving therapy, followed by sentinel lymph node biopsy. 2 lymph nodes were sampled and they were negative for malignant cells. She was diagnosed as pathological T2N0, M0, invasive breast carcinoma with medullary features, grade 3, and margin was negative. The immunohistochemistry was done, which was suggestive of triple negative breast carcinoma based on the absence of immunoreactivity in ER and PR receptors and the absence of HER2-neu. Ki-67 was in the range of 35 to 40%. BRCA testing, however, was not done. She was offered adjuvant dose-dense chemotherapy with adriamycin, cyclophosphamide, and paclitaxel, and was later referred to India for radiation therapy. Radiation was given in the whole part of her right breast, followed by tumor boost in the tumor bed. She has been under follow-up every 3 monthly and is doing fine. In the total breast carcinoma group, triple negative breast carcinoma comprises around 15 to 20% of the population. In the triple negative breast carcinoma, BRCA1 comprises around 60% patient, while BRCA2 comprises 20% of the patients. And most of these patients relapse in the first 3 years of their disease. So usually the relapse is in the locoregional areas, including the axilla or the breast, or in the liver or the bone. As we see in the slide, compared to the localized triple negative breast carcinoma and locally advanced disease, the survival rate of such patients is very poor when the disease gets metastatic to other areas. So the 5-year survival rate of such patients is around 11%. Maybe the poor outcome of survival in such patients, in the overall patients, might be because of lack of targeted agents in triple negative breast carcinoma and the development of resistance whenever we give chemotherapy to such patients. So when following diagnosis of the patients, after we do a mammography and biopsy of the breast lesion, we check for the axillary lymph nodes. If there is any lymph node in the axilla, we aspirate the needle to see if there is any cancer cells in it. If the axillary lymph nodes do not have any clinical evidence of lymph nodes, we do a sentinel lymph node biopsy. In this sentinel lymph node biopsy, a radioactive substance dye is injected to the tumor cell first, and we visually detect or by device where the dye goes to. The first lymph node which shows this dye is then removed, and we check it for cancer cells. These samples are then sent to a pathology lab where a histological diagnosis of breast carcinoma is given. But for a proper treatment therapy options, we need to find out whether the breast specimen express the immunoreceptor, the estrogen receptors, progesterone receptors, or the HER2 expression or amplification is there or not. So a triple negative breast carcinoma is diagnosed when the tumor cells will have less than 1% of the estrogen receptors, progesterone receptors, or there are absence of HER2 overexpression or amplifications. After the diagnosis, when the patient undergoes surgery, the breast sample and the regional lymph node sample is again taken out and is sent to the pathologist, and we look for the residual evidence of cancer in such specimen. If there is any residual evidence of cancer cells in this breast specimen or the lymph nodes, we say that the patient is not having complete pathological response. But if there are no residual cells, then we say that the breast cancer has gone a complete pathological response. We will discuss about the importance of this pathological response later on and its therapeutic implications. So when the patient goes for surgery, the surgeon and the patient preference will decide whether the surgery, the whole of the breast will be removed, that is called mastectomy, or the patient wishes to preserve or conserve the breast. After the breast conservation or mastectomy is done, we need to take care of the axillary part. This is called axillary management. So like in our patient who had 1 or 2 sentinel lymph nodes evaluated, the sentinel lymph node was not detected to have cancer cells. So she did not undergo axillary lymph node dissection. But in other patient groups who have more than 3 sentinel lymph node positivity, or even if there is 1 or 2 sentinel lymph node positivity, but if the tumor cell is large, more than 5 centimeter, or if there is extranodal extension, then the surgeon take these patients for axillary lymph node dissection. After the axillary lymph node dissection and surgery has been done, this patient take on the adjuvant chemotherapy. Adjuvant chemotherapy is giving chemotherapy after a definitive surgery. Like in our patient, we offer them adjuvant chemotherapy when the size of the tumor is more than 5 centimeter, or if the size or if the nodes in the axilla is positive, then we give them adjuvant chemotherapy irrespective of the size of the tumor. So especially in triple negative breast carcinoma as compared to other hormone receptor positive cancer, whenever we give chemotherapy, it is always beneficial, whether we give it before the surgery, that is called neoadjuvant chemotherapy, or if we give it after the surgery, that is called adjuvant chemotherapy. So in both the cases, it has been shown that the 5-year risk of recurrence of the disease, cancer, or the risk of death is found to be less, especially when we give chemotherapy to a triple negative breast carcinoma. So we give adjuvant chemotherapy dose dense. The dose dense chemotherapy in adjuvant setup, the backbone is comprises of 2 groups, anthracycline and taxane. Anthracycline, we used adriamycin with cyclophosphamide. We gave it in a 2-weekly regimen for 4 cycles, and paclitaxel can be given either 2 weekly for 4 cycles, or it can be given every weekly for 12 cycles. So there were research where one group received only the anthracycline groups, where the other group received both the anthracycline and the taxane group. So when they combined these two chemotherapy, the patient had lesser chances of recurrence of the cancer. The death because of the breast cancer was low, and the overall death of the disease of the patient was low when we combined this two chemotherapy. When patient had cardiac issues, then it is better to avoid anthracyclines in view of its side effect. So we can choose docetaxel and cyclophosphamide instead. As I mentioned in the initial slides, there are two schools of thoughts: either giving chemotherapy first, going for the surgery, or doing a surgery and going for chemotherapy. What I want to state is, in the past, adjuvant chemotherapy, that means first giving a surgery, then going for the adjuvant chemotherapy, was the norm, especially in all type of breast cancer cases. But nowadays, more and more patients are receiving neoadjuvant chemotherapy. So the principle behind this is, whenever we give chemotherapy to a patient before surgery, the systemic micrometastasis will decrease, the size of the tumor will decrease, and it will be easy for the surgeon to preserve or to conserve the breast. The patient response to the chemotherapy can also be detected if we give early chemotherapy. And most importantly, especially in the triple negative breast carcinoma, as in on the case that we are discussing, even small size, like around 2 centimeter, we give neoadjuvant, people are giving neoadjuvant chemotherapy. The benefit would be, when we give chemotherapy, after that we do a surgery and we see whether there is a residual tumor in the specimen or not. If the patient has got some residual disease in the specimen, there is always a scope of giving adjuvant oral chemotherapy further on. And it has been shown that when we add on this oral chemotherapy, the outcome of the patient will be good. So proponents of the neoadjuvant chemotherapy have been claiming that it is always better to start chemotherapy first, followed by a surgery, to evaluate the residual effect and add on some other therapy. So the other indications for giving a neoadjuvant chemotherapy can be if the patient has a locally advanced breast cancer. If the lesion in the breast is very big as compared to the breast, then for the cosmetic purpose, the surgeon advises us to give a neoadjuvant chemotherapy. If in the axilla, the lymph node is very small, so irrespective of the primary size of the tumor, we advise neoadjuvant chemotherapy. And yes, of course, if a patient is contraindicated to go for surgery, then we first advise them neoadjuvant chemotherapy. So the chemotherapy options that we use in the neoadjuvant setting is the same as that we use in the adjuvant setting. But especially in TNB, triple negative breast carcinoma, in BRCA gene testing had been done. Then people have studied about the role of new chemotherapy, that is a platinum group of chemotherapy, namely cisplatin and paclitaxel and carboplatin. What has been shown is the pathological complete response is better with these on adding this chemotherapy. But in the long overall run, there is no overall survival benefit even on adding this third agent to the chemotherapy list. So in view of the toxicity profile of this platinum, it is advisable to stick to the anthracycline and taxane backbone, not to add platinum in it. So now, what is the pathological complete response, which we have been discussing in triple negative breast carcinoma? As I earlier mentioned, when the surgical specimen of the breast has been removed out and the regional lymph node has been taken out, we study whether there is any residual tumor in the primary or in the nodes. So if there is no residual tumor in the primary, or only in situ tumor in the primary or in the nodes, then we see that the patient has attained complete pathological response. Why are we talking about complete pathological response in the TNBC? Because in most of the patients, around 1/3 of the patient of TNBC have shown to have pathological complete response. And this percentage is increasing when the newer agents have been in use lately. And it has also been proven that whichever patient has got this kind of response, the survival chances without a disease is very long. So the disease-free survival chances is very long, especially in pathological complete response. And suppose even if we give a neoadjuvant chemotherapy, but the patient has got some residual disease, then the chances of relapse will be around 20 to 30%. So suppose if there is a residual disease, then what should we do? So to study about this problem, doctors from Japan and Korea did open level randomized phase 3 trial, and this trial was published in NEJM 2017. It studied the concept of giving adjuvant chemotherapy, especially to residual tumors. So they took stage 1 to stage 3 breast carcinoma patients, HER2 negative patients, and the neoadjuvant chemotherapy was given. After that, patient was taken to surgery, and they studied the pathological response in those patients. So whichever patients who had no pathological response, residual disease, they were subjected to either the capecitabine arm or a standard group therapy with hormonal therapy. So capecitabine was given in the dose of 1250 milligram per meter square from day 1 to day 14 every 3 weeks for 6 to 8 cycles. And it was seen that especially in the triple negative breast carcinoma, the patients without a disease, around 60–70% patients had disease-free survival. And this was reflected in the overall survival rate improvement. Around 79% had improved overall survival rate. So this study has had 30% of the triple negative breast carcinoma, and the residual disease was seen in 60% of the patients. But yet another study was published that was in a next journal in JCO in 2020, which also studied giving this adjuvant capecitabine in operable triple negative breast carcinoma. These patients also had received neoadjuvant followed by surgery, then capecitabine, but it didn't show any improvement in the disease-free survival. However, since it was done in the triple negative breast carcinoma, it is a very heterogeneous group. They found out that in small subtype, that is non-basal phenotype, it of course had superior disease-free survival and OS benefit. So we must be wondering that there are two different studies. One study showed that there is benefit with giving oral capecitabine, while the other study showed that there is no benefit. So the people have reflected on this and have commented that most probably the second study which came had low power with less number of patients, and the number of patients that were included in this trial had high risk of relapse. And moreover, the important other hypothesis that was generated was maybe the previous study that was done in the CREATE-X trial, they had residual disease. Residual disease means the patients were non-sensitive to the previous neoadjuvant chemotherapy. So whenever we give some new agents, new tablets, then these patients might have been sensitive to this new therapy. That was the hypothesis that was generated. But still, from my personal perspective, what I would say is, since the triple negative is a vast heterogeneous group of disease and molecular subtyping need to be done, and since it has shown that even in non-basal phenotype, they had superior DFS and OS. So when we encounter patients who had pretty poor outcome, this can be one hypothesis generating evidence for which we can add on new adjuvant trials, and we can practice giving new adjuvant. So after the patient received adjuvant chemotherapy, like in our case, we advise these patients for the whole breast radiation therapy. So whenever the breast conservation surgery is done, these patients are indicated for whole breast radiation. Even when the total mastectomy has been done, we give them chest wall or regional lymph node radiation, especially when the patient has got lymph nodes around 1 to 3 in the axilla, or if more than 3 with other high features like T3, T4 disease. If the margin is positive with other prognostic features like patient's age is less than or equal to 50 years, T2 or higher primary lesions like high grade patients and patients with the triple negative histology or lymphovascular invasions. These patients with T2 and T3 with poor prognostic features, these are also advised for chest wall and regional lymph node radiation. And these triple negative histology, if they receive radiation therapy, the survival outcome has been shown to be better. There are newer evolving investigational approaches that have been tried in neoadjuvant chemotherapy in the case of triple negative breast carcinoma, namely the PD-L1 inhibitors like pembrolizumab, atezolizumab, or durvalumab. And also when we do a BRCA testing in patients, we can keep them in clinical trials giving neoadjuvant with velaparib and talazoparib. What I want to mention here is all these agents have improved the complete pathological response in triple negative breast carcinoma, but the long-term survival has not yet been validated. So I think we need to combine many agents to see the response to the disease. In this short summary, short presentation, I would like to summarize that especially in triple negative breast carcinoma, immunohistochemistry is very important for diagnosis and choosing the right therapy. Overall, though there are a heterogeneous group of disease in the triple negative breast carcinoma subset, but overall TNBC has got worse outcome. But if we choose judicious treatment options in the early stage, we can have better outcome in such patients. We can always offer them neoadjuvant chemotherapy with the aim of conserving the breast and with the hope of adding some additional newer oral chemotherapy in case of residual disease. And yes, of course, adding radiation therapy improves overall outcome in such patients. I would like to thank everyone for listening. Thanks MMA and Dr. Nasida for this opportunity. Thank you.
Thank you, Dr. Kamal. Most of the names would have gone above our heads, but it was very interesting to listen to your presentation. If anybody or anyone has a question to Dr. Kamal, shoot. Or maybe at the end of all the presentations, we can have a question session.
Thank you.
If there are no questions for now, let's move on to the last presentation by Dr. Murari, consultant cardiologist. It's about antiplatelet therapy in PCI. Dr. Murari, if you are here, please proceed with the presentation. So I think Dr. Murari is getting ready for the presentation. Before that, I'm so happy to note that so many participants have joined to listen to these presentations. And it was a difficult time, and it is a difficult time for all of us and all of you. And especially the physicians are held up in different works involving COVID and also non-COVID illnesses. And with this short notice, it is almost a miracle that we are having this CME at this time. And so I think Dr. Murari is ready. The screen is yours. Please continue.
Thank you, Dr. Mohamed. Am I listening? Am I hearing to you? Okay. Good evening, everybody, my colleagues and my members of medical fraternities. I feel honored to present a topic which is quite important for most of us. Either you see it today or tomorrow or anytime, and any faculty member of the faculty can have this issue of having antiplatelet therapy either in the surgery or medical or doing any procedure. Coming to the topic as such, most of the presentation is based upon the recent guidelines which are updated in 2018 for the European Society of Cardiology and updated guidelines for the non-ST elevation MI in 2020 ESC, because American College of Cardiology guidelines lag behind in this regard, and they were a little bit old in 2016, but still we'll go head by head. And so I'll be focusing main on how to manage antiplatelet therapy who are going for any percutaneous coronary intervention. But before going to that, I would like to show that the PCI have been evolved over the period of last 40 years from different phases. The first pioneer of this is Dr. Anders Gruntis from Switzerland in 1977. Gradually, we know that stenting with the metallic scaffold is better to prevent the acute recoil. Then we found that it goes into development of stenosis by the proliferation of the muscle and fibrous tissue. Then we started adding anti-proliferative drugs. And after adding the drugs, we know that the anatomy of the vessel is changed, that it is no longer covered by endothelium. So there is high likelihood that blood will get in and get clotted. So all of these things we have come across through some conclusion and some finding that we want to patient safety and efficacy. So coming into the point of antithrombotic therapy, depends upon the comorbidity, clinical presentation, patient other characteristic, all etc. And basically there is a trade-off between the thrombotic risk and the bleeding risk, and we should have a balance between them. The optimal therapy is prevent all the thrombosis and have no bleeding, but the ideal situation doesn't exist, and there is some trade-off between them. So these are the current available drug therapy which are targeting the special pathway for prevention of thrombosis. They have been divided into antiplatelet therapy, anticoagulant therapy, and thrombolytic therapy. We will be mainly focusing on the antiplatelet therapy, but anticoagulant also come into play while we go for PCI. So basically aspirin halts the enzyme, the platelet enzyme thromboxane A2, cyclooxygenase in the platelet by preventing the generation of the thromboxane A2, whereas the P2Y12 receptor, P2Y12 antagonists like clopidogrel, prasugrel, which comes under the chemical name of thienopyridine groups, and the newer one as a ticagrelor and cangrelor, they prevent or blocks the ADP receptor, whereas GP2B3A acts directly on the GP2B3A for activation, so that platelet cannot aggregate and it cannot go into the thrombus. And there are anticoagulants are either vitamin K antagonist or newer, which we know as NOACs, and it is available in Maldives as well. So you need to know them. So mostly rivaroxaban is currently available, but we have a dabigatran, ipexaban, and etoxaban that are FDA and FC CE mark. The red ones are having only in the parenteral form. Let's change our shift our gear to stable angina, chronic stable angina, unstable angina, and ST segment elevation MI as we divide our coronary artery disease, and accordingly the choice of the therapy and duration of therapy differs. So in patient with a stable angina, most of the time always we need aspirin along with clopidogrel. Only if we have a high risk features, like we see a development of thrombosis during PCI, or we are doing high risk like left main bifurcation stenting. In that case, is a class 2B indication that we can use a highly potent agents like prasugrel or ticagrelor. But in general, we use aspirin and clopidogrel. We need to use a loading dose. And I would like to say here is that we can give aspirin and clopidogrel at the time of intervention, just after angiography, we need not give from the very beginning unless we know the coronary anatomy. And researches and studies have shown that it is feasible and it will cause less bleeding, and there is no price to pay. So how long to treat is always the answer. And we see most of the time people are getting dual antiplatelet therapy, not for years, for decades. We see even after a CABG, patients are getting DAPT, which is not the correct choice. And there are many studies to show that if it is given more than required period, there is very little bit of additional advantage of having lesser thrombotic event, but there is higher chance of having bleeding events. So that is not encouraged most of the time. So in general, if in a stable patients, the current guideline, both SCC and ESC, European and American counterpart, 6 months therapy is adequate in most of the cases. If there is higher bleeding rates, then you can shorten it, abbreviate up to 1 month to 3 months. So even 1 month is okay if it is high bleeding risk. I'll come to that, what is high bleeding risk and what is low bleeding risk and what is high thrombotic risk. If you feel that patient is not bleeding and if the bleeding thrombotic risk is high, that means patient's propensity or risk to have another coronary event is high, then we can prolong, and data is showing that up to 30 months of data is there. But beyond 30 months, we don't have any data, and there is no much required. The idea behind this is that the most of the time we give a dual antiplatelet therapy to prevent stent thrombosis, to prevent recurrent MI. And the most of this occurs within first month. And with the current generation of the stent, current generation of the technology we use in the treatment of the coronary narrowing, there is not much required dual antiplatelet all the time. I mean, all prolonged period. If we go into the non-STEMI, it is an acute coronary event. So the platelet are activated fast, and this is a different scenario. And so we need to give a more potent inhibitors. Aspirin as such is given in the same dose, loading dose followed by low dose or baby aspirin, they say in America, and we give a 75 milligram. The baby aspirin dose is 81, which is available there. Then we must also give a P2Y12 receptor antagonist or inhibitors. And here the preferred drug is the more potent, either prasugrel or ticagrelor if it is available, if it is not contraindicated. The basic contraindication is history of TIA or stroke in the past. And we have to load both of them and give for a period of time, which I'll come. And if it is not available, then the second best choice is clopidogrel. And the other medicines, this G6, GP2B3A like erseximab, tirofiban or eftifibatide has to be given only if it is a bailout. For example, if there is no flow or there is any visible thrombus at the time of intervention, or it develops newly. And if patients are new to the P2Y12, we can consider cangalore, which is an IV P2Y12 receptor at the time of PCI. So this has been currently modified or revised in 2022 guideline. The basic things is most of them are the same. The thing is that prasugrel is more preferred over ticagrelor in the non-ST segment elevation MI if it is available. The next best is of course ticagrelor, and after that is clopidogrel. And if we are going for invasive therapy, that is angiography and angioplasty, it is not required to have routine loading with the this medicine. We can do after angiography. So duration, how much to do? Because they are a higher risk of patient, we want to give it for a longer period. But again, there is a category of low bleeding risk, high bleeding risk, and very high risk. The very high risk is patients who have already have some bleeding in last 1 month or have a surgery. Then these are a very high risk. Then high risk and low risk, I'll come what are the features of high risk in a later time. In general, we have to give for 12 months. So we can give either aspirin with prasugrel, aspirin or ticagrelor, or aspirin and clopidogrel. After 12 months, if there is a high ischemic risk but low bleeding risk, we can extend, as we have told before, we can extend up to 30 months in general. So either I can give a aspirin with rivaroxaban, that is a NOAC, but in a low dose, 2.5 milligram BD, or we can extend the same thing for more than 12 months. The other idea is that if after 3 months, if it is a low risk, relatively low risk bleeding and relatively low ischemic risk, after 3 months, we can drop off the aspirin and continue only ticagrelor. If there is a high bleeding risk, we do not want to give a highly potent drug, we'll give aspirin and clopidogrel alone, and we can drop off clopidogrel after 3 months. If very high risk, we can drop off aspirin after 1 month, so that we continue for 12 months of clopidogrel. So these all have been tested in studies. That's why they are given in the guideline. Sometimes there appears a situation that we have to switch between P2Y12 receptor for various reasons. One of the reasons is bleeding. The more potent you give, the higher bleeding rates will be there. And sometimes it's because of the cost. The newer agents are definitely much costlier than the older clopidogrel, and sometimes it may not be available, especially in case of Maldives. And the one point is that clopidogrel response is highly variable, especially about 30% of the population can have a low response, because it depends upon the this hepatic cytochrome P450 isoenzymes, CYP3C19. So they have a multiple allele. If it is a wild type, then they act well. But if it has a change in the allele, then the response that changing from clopidogrel prodrug to the active drug is hampered, and the effect of the drug is reduced. So that point is also been tested, and if available, it has to be tested. And if it has a wild type, we can very confidently use this medicine. But if not, then we have to consider really. And so if situation demands that we have to switch in acute setting, that is within 1 month of PCI, we have to always load the we have to give a loading dose. Unless if it is because of the bleeding issue, then we are shifting to the clopidogrel. In that case, we should not load. Otherwise, we have to load. Normally, we load after the last 24 hours after the last dose. If it is chronic setting, after 1 month of PCI or 1 month of the event, then loading is usually not required except for ticagrelor. In ticagrelor, we always load after 24 hours. But in Other drug, clopidogrel and prasugrel, we do not load. Coming to another scenario, ST segment elevation MI, which is the highest thrombotic risk. So it has a more clear evidence and more clear answers. So again, we have to give aspirin at the lowest dose. And P280, preferably we have to give a potent only if they are not available or because of cost issue or because they are contraindicated, then we can give clopidogrel as a second choice. Then again, GP2B3A as a stem therapy is not recommended, only as a bailout is to be given. And in a case who has not received P280 inhibitor beforehand, they can be given either Cangalore or 2B3A as a 2B indication. So how long to give? Again, if it has a low bleeding risk, we can give 12 months of therapy followed by any of either of them, which can continue more than 12 months up to 30 months. Or if it has a higher risk, then we do not, for bleeding, we can stop at 6 months. Another situation is that patient is already getting some form of anticoagulation. They develop MI or they develop a stable angina and exhaustion, and we need to go for PCI and put on a stent. So how to deal with them? This is also one of the common scenario, as about 5 to 10% of people will have either atrial fibrillation, or some of them may develop venous thromboembolism or some other issue, or even somebody may be having mechanical heart valves or like that. So most of the time, so the situation is we have to tackle both the venous thrombosis as well as arterial thrombosis. Most of the time, we tend to give about a month, but the situation is changed right now. We want to tend to give triple therapy as short as possible, and if possible, in non-valvular AF, we want to give NOAC. And if we must give PK, for example, in people with mechanical heart valves, then the INR should be in the lower range, like 2 to 2.5. Then, and we must discontinue after 12 months of all the antiplatelet therapy, of all, even the aspirin, for this indication. So, and if we are combining, we can change our dose, like rivaroxaban, 15 milligram will be enough instead of 20 milligram. But in case of dabigatran, 110 is not adequate. And ticagrelor or prasugrel, we are more potent, are not recommended as a triple therapy anytime. Or even dual therapy is not tested. So basically, is it a game between the bleeding and ischemic thing, and the balance between them is a must. So the conditions that increase the chance of having recurrent ischemic events are like diabetes, recurrent MI already has occurred twice or thrice, any multivessel coronary artery disease more than 2 vessels, any polyvascular disease like coronary artery disease with peripheral artery disease, premature MI like less than 45, accelerated like have a event more than 2 times within 2 years, and concomitant systemic disease like HIV, SLE, or rheumatoid arthritis, or CKD with GFR less than 50. So these all are the enhancer for the risk of recurrent thrombosis, and which can prolong DAPT in such cases. And if we have technically during the procedure, if we are more stent use more than three lesions, total stent length is more than 60 millimeter, then if we are doing complex like left main intervention, bifurcating lesion with more than 2 stents, CTO intervention, stenting of the last patent remaining vessels, and if already patient has stent thrombosis, these people are having a higher and much higher risk of recurrent thrombotic events, and we need to give consideration increasing the duration of antiplatelet therapy and giving a stronger antiplatelet therapy in such cases. Whereas bleeding risk has been defined by different criteria, and we have a different risk score, like precise DAPT scores, which is available as an app in the mobile. But this is the ARC criteria, which is more comprehensive and give more idea, but we have to remember this. How we remember is most of the time I tell that we remember your colleagues of other department, like liver cirrhosis, like thrombocytopenia, like malignancy, like ICH or AVM or stroke, or your surgical colleagues. Like you cannot avoid surgery within a month, or have a recent surgery or major trauma within 30 days. So these are the people are more likely to have much bleeding. And bleeding is bad. After PCI or after heart attack, if you get a bleeding, it not only halts or only bleeding per se, because you have to stop antiplatelet. Antiplatelet is stopping the risk of having stent thrombosis, and recurrent MI is very, very high. And that's why people have studied in a registry data that these people, the mortality rate is much, much higher. And if we give a triple therapy for a long time, the more chances of bleeding is almost 3 times than the dual antiplatelet or single antiplatelet therapy. So the strategy, especially in the high risk bleeding, so what we can do is we have to be more cautious. So we call it SVR patients during PCI. So we have to be more cautious and vigilant. We have to give an anticoagulant dose based upon the body weight and renal function, and not just like 10,000 or 12,000. Radial access is much more preferred to decrease the access site bleeding. PPI is especially useful, and we usually prefer to give in all of the patients, but they are more important if we are treating more than 65, having staph dyspepsia, GI reflux, S. pylori, and if patient is on oral anticoagulant, rather than breathing, we can continue the Vicky or NOAC drugs. And if INR is more than 2.5, we should not give heparin during the PCI. And if it's on NOAC, we have to give a lower dose rather than a higher dose, like heparin 60 instead of 70 to 100 unit per kg. And aspirin is indicated, but pre-treatment with P2Y12 is not discouraged, and GP2B3 is usually not given, not preferred. So as we must give aspirin lowest dose less than 100. Clopidogrel should be used as a P2Y12 receptor, and target INR in the lower range of 2 to 2.5 if we have to use. And if and NOAC can be used, for example, in non-valvular AF, it is better than VK, and duration of triple therapy should be as low as possible. So the duration, if patients having AF already having an anticoagulant is going for PCI, then we have to again see high bleeding risk or high ischemic risk. In general, we can give 1 week of triple therapy. We call it TAT, or triple antithrombotic therapy. NOAC plus DAPT, usually aspirin and clopidogrel, normally NOAC. Then after 1 week, in general, in default strategy, we drop off aspirin for next 12 months. If it is a stable angina, we can stop at 6 months or even 3 months. if bleeding risk is high, after 3 months, after 6 months, we can go off, drop off altogether antiplatelet, only NOAC. And if ischemic risk is high, we can give up to 1 month of triple therapy, then we can drop off aspirin. And after 12 months, only NOAC is given. There is no need of aspirin. Because the more time you give, the more likely bleeding will occur, and there is no added benefit. So coming to the conclusion, aspirin has to be loaded by 150 to 300 milligram non-interrecorded drug. And after that, 75 to 100 and not more than that. And there was initially people used to give twice daily dose for 1 week or 2 weeks or sometime even 1 month. But the studies have shown that it is not required right now. And if oral anticoagulation is needed, we can drop it from 1 week to 1 month post PCI in a stable patient and about a month in acute coronary syndrome people. And if patient is P2Y12 new, he has not been preloaded, then we can give a IV congalor if it is available. Unfortunately, it is still not available. And if we have to give this one, we should give wait for 2 hours after the IV congalor. Then only we can give this P2Y12 receptor, because all the receptor will be blocked by congalor. So you cannot give along with congalor. If you give clopidogrel or prasugrel, then the effect of clopidogrel is lost. And most of the ACS patient combination prasugrel may be favored in the ticagrelor in current studies, current line. So favorable is prasugrel if it is available. Then next is ticagrelor, and if not available or not suitable, then clopidogrel. So for the most stable cases, clopidogrel. And the duration of DEPT is for 6 months in general, 6 months for stable patient, 1 year for unstable patient or acute coronary syndrome patients. If there is higher bleeding risk, we can cut it to half, 3 months and 6 months. If there is higher ischemic risk, we can go off to extended period up to 30 months. So this all depends upon the balancing the ischemic risks and bleeding risks based upon the patient characteristic, clinical presentation, comorbidities, co-medication, and procedural aspects. Thank you for giving me this opportunity, and thank you for listening me.
Thank you, Dr. Murari. Thank you all the presenters for these awesome presentations which you have presented. I think it comes to a conclusion now. So if there are any questions from any of the participants, you can ask now, even in the chat bar, or you can unmute your mic and please ask. So on behalf of Maldivian Medical Association and the medical fraternity, we would like to thank you, all the presenters, for presenting such a wonderful presentations, and it was all very interesting, and you have given your utmost most effort to give to deliver the presentations on time, and it was in detail, and you have given a lot of time to make the presentations. We are very happy for your presentations. If there are any Maldivian Medical Association EXCO members who would like to say something, for the presenters can please unmute your mic and say some words, or we'll be concluding by now.
Thank you, Dr. Palani, Dr. Bhumika, Dr. Kamal, and Dr. Murari. Actually, it was in very short notice that they have prepared these wonderful presentations, and I appreciate all the effort. And definitely, all of us who have been in this meeting had learned a lot of new things, and we hope to continue this kind of CMA from MMA. We enjoyed all the presentations. Thank you so much.
By the way, this is written in history. You will be, this is recorded and it is in live on the YouTube. You can watch it later through the MMA YouTube channel. So we are happy to, I'm happy to host this CME. I think it's time to say goodbye. Have a good night to all of you. Thank you once again for the presenters and for the participants.
Good night. Thank you, Mohamed.
Thank you all.